He was diagnosed with osteochondritis discans. They determined that microfracture surgery was the best option. So he was in physical therapy for about 2.5 to 3 months post-surgery with a different PT. And he came back physical therapy because he was still having pain, and his surgeon wanted him to continue physical therapy for another 2 to 3 months due to soreness at his follow-up session at 6 months. Currently, when he came in, he still wasn't allowed to compete in any running or jumping. And he is a basketball player. So that's something that he's been limited for almost a year now. So that's got to be pretty frustrating as a 15-year-old kid. So any questions after subjective?
Do you know what the prevalence is for OCD?
I want to say, I did look it up. I think it is 1 in 300,000.
Yeah.
Kids around that age.
Yeah, it's not too common at all.
Yeah, it's not too common, I was reading, but I've probably seen about 4 kids now in 2 years who've had to undergo this microfracture surgery. So apparently if you live in Spokane, Washington, there's a higher incidence of it.
Or there's a surgeon that wants to work on it.
Yeah, that's right, yeah. We learn you get surgery based on your zip code.
Right. So it's one of those things that, so it appears, so they get knee pain, they image it, and then it appears on the image. And then, how do you tie, is there a correlation between the image and the actual complaint?
Mm-hmm.
And I don't know, so if the prevalence is low and then you look at the actual correlation between, finding it and then that being the cause of your symptoms, I bet that's even lower,
Yeah, definitely. And since the prevalence is so low, actually, I forgot to include this article in my case study before I turned it in, but went to the American Academy and Orthopedic Surgeons website, and they had a case study going on. And basically, just sum up this case study, there's really no good evidence straying surgery or non-surgery either way. So it's kind of unknown in the surgical world too, as far as the orthos go, whether it's going to work. So it's almost like a toss-up. I know at least here it seems like if PT fails, they end up going to get surgery, and usually surgery ends up helping quite a bit, but I know it's not a high prevalence.
Yeah, and it's hard to say with this case, so there's 2.5 to 3 months of, how much PT did he get prior to the surgery?
He didn't have any prior to the surgery.
Oh, great.
Yeah, so he was one that just went straight to the surgeon, and the surgeon operated.
Awesome. Okay.
So going down into objective, I actually started with the SFMA, and all I looked at the SFMA is I went to the squat breakout. And so when he did a squat with an overhead reach, it was actually dysfunctional, non-painful. Nothing was bugging him this day. Squat with the non-overhead reach was dysfunctional, non-painful. When he broke it down further, when he pulled both knees to his chest, his anterior thigh was not able to touch his chest at all, so that was dysfunctional, not painful. When you broke it down and looked at his lats, that was also dysfunctional, non-painful. When you got to the ankle, I call it the ankle 90-90 test, when you're trying to put go into dorsiflexion in a lunge stance. He was about 3 finger widths that need a pull, so he was really limited in his ankle mobility. During the squat, I observed that he had increased knee translation way in front of the toes, so he was a really big quad loader. He had significantly increased trunk flexion and failure of hips to break 90 degrees with a non-parallel trunk and tibia relationship. And all his weight bearing went on his toes, and he didn't hinge from the hips at all. So he is a significant quad loader in the squat world. I noticed just like when observing him, like throughout his previous PT sessions with the different PT, that he almost always walks on his toes. Like it's very hard for him to like heel strike and like go through a normal gait pattern. And whenever he was doing exercises before, he was always on his toes. So he was always promoting that pattern of quad loading. Getting down a little bit further, hip external rotation, or like the posterior glute knee test too, is about 3+ out of 5 bilaterally. His ankle talocrural joint mobility was actually normal, but he had quite a bit of tonicity in both calf muscles. Any questions after the objective?
What other types of things would you guys have done, would you have tested? That's a question to everyone else. Most of you are muted, so unmute before.
I would do like, did you do like a straight kind of manual muscle test for the lower extremity as well? Other than the SFMA stuff?
Yeah, I did the posterior glute med and I did hip external rotation just in sitting.
Yeah. I don't know. I guess, well, and then what about like lumbar spine? Did you clear the lumbar spine to make sure it wasn't anything referring?
No, I didn't.
Yeah, I probably, well, I don't know. I have to do it for my back. But anything that's lower than like, anything that's lower extremity, always trying to clear like the lumbar spine. And then I always go through kind of all my different manual muscles to test stuff for especially my knee patients as well, because usually there's different things that come up that I think affect their mechanics and stuff as well.
Mm-hmm.
So
that's just what I do.
If you're clearing the lumbar spine, are you clearing like a radiculopathy, or are you clearing the SI joint? Like, what's the connection?
Well, right. So I guess, yeah, just doing kind of some cardinal plane movements and stuff and see if there's anything that, affects the knee joint or affects kind of like that pain into the knee. Mm-hmm. So I'll probably just do kind of the different motions and stuff, see if I can provoke anything. And then I always just do like a quick run through.
Well, it's good that you're doing that too, because I know Chris has talked about with the repeated motions that if you're not loading through one part of your spine, you're probably not loading through that hip and that knee properly. So doing the repeated or doing the lumbar exam for that purpose is going to be really beneficial. But then also even doing some of the functional stability tests, looking to see how the core is responding to different perturbations, is going to directly affect what's happening at the knee too.
You mean like functional stability stuff like outside of the SFMA?
Outside, yeah, that's just like the elbow break test or the axial compression. Those three tests. So, or any test that really is going to assess how the core is functioning in a more dynamic position.
Any idea for quad strength?
I would do like an eccentric step down test.
Yeah, exactly. So just like a lateral step down test or something like that. Compare side to side, looking for any type of valgus or any type of impairment there.
Hey, then Carson, what other muscle groups should you really test out in knee patients?
Like hamstrings and plantar flexors. Yeah,
I'm thinking mainly plantar flexors. I see so many patients with knee pain that have just like such weak calves. So.
Especially running and jumping and that sort of stuff.
But yeah, otherwise it looked good.
Okay. Yeah, this kid's like all calves. Like,
okay.
Like all strength is in his calf. But yeah, so to continue there. So basically, like first time, I mean, he's a kid that like you could spend. I just call him like it's mean, but I always just call them like motor morons. Like you could spend all day kind of breaking down each section of them. and finding faults. But so like for like just that initial evaluation, we basically just broke down his squat. So kind of like the outcomes I used was I keep going back to his SFMA squat breakout. So after each session and before each session and throughout the session, we always test his overhead squat. We always test it with an overhead reach and then with the non-overhead reach to see if we're gaining any control over it.
Does he have any pain during any of this? Like during the evaluation or anything like that?
No, like he was having pretty significant pain in the past, but by the time he actually made it into PT, he's actually doing a lot better. I'd say like when he would try and go like actually run on his own and stuff and test it out a little bit, that's when he'd get his pain. But during PT, he never had any of it, which I was kind of surprised because just the way he moved, it seemed like some squat stuff was going to bug him.
Mm-hmm, mm-hmm. So your asterisk sign, what would you say your asterisk sign was? The squat?
Mm-hmm.
So then
that's the big one that we keep going back to.
So then you're looking at mainly at what? If you're looking at like the treatment paradigm, so if the asterisk sign is squat, were you looking at changing motor control or strength?
Yeah. Okay. Yeah, so definitely like for me, I was primarily looking at like, can he start to hip load versus quad loading? Can he get his trunk more upright? Can he get his trunk more parallel to his tibial plane? Stuff like that.
Okay.
And then just looking, like I guess I could have put another asterisk sign on there, is just his overall gait and seeing if he's starting to get like a heel to toe walking pattern down too.
I mean, do you think that the gait was just a compensatory because of knee pain, or is gait just something that he's always done? Like I don't know if that's going to be something you're going to be able to change. You know.
Well, I'll say like if we got to it like a little later on, gait has changed a little bit, but just with calf mobility and stuff like that. And I think actually just by making him aware that, heck, hey guy, like, have you ever noticed that you're walking on your toes all the time? Like it's okay to step on your heels a little bit too. Mm-hmm. It's just something that he's not really even aware of per se. So it was interesting. So I'd say it's not like fully normal, but it's something that has changed over time.
Question for Dana. Would you consider that like pathological though? Just somebody that's just toe walking, but you know?
I mean, I think you'd have to find it in the presence of other things. You know, I think if it's just toe walking by itself, it's not pathological. But if there's knee flexion, you know, along with that are some cognitive things or, you know, I think then that's probably when you'd lead more towards a pathological gait. But in the absence of CP or things like that, I'd say no, it's just something that he's done, you know?
Mm-hmm. Yeah, I never quite thought about it that way. Mm-hmm.
Did you happen to look at tibial internal external rotation? And then also, how was his hip mobility?
Yeah, so further on down the road, his hip is really tight into hip flexion. So he just doesn't have like great gliding of his hip joint in general. Okay. Tibial internal and external rotation, we checked at a later time, and he's actually pretty good in those areas. As far as like the getting into that hip flexion, in order for him to get in like kind of a wide squat stance or do anything to where his he's not going to get that impingement, he has to go into some external rotation.
Okay. So are you doing some manual therapy on that now?
I haven't done too much manual work, but I've been doing a lot of work with the mobility bands and actually like repeated hip flexion and stuff like that.
Okay. Good. So yeah, you're addressing the mobility impairment somewhere at least.
Mm-hmm.
Okay, good.
So hip flexion is limited. Is it limited in a sort of when you test it neutral? I mean, if you abducted the hip and externally rotated it, is the hip flexion full then?
Yeah. Mm-hmm.
So it's not necessarily like a pure flexion. per se.
Yeah, I guess the only, like when I tested, it's like when he's just fully on and when it's in line with the sagittal plane,
Yeah.
he's really missing a lot of hip flexion.
So he's probably missing some internal rotation there as well.
Mm-hmm. Yeah, and at a later time we tested out, and I mean he's probably only got like 25 degrees of hip internal rotation, so he's definitely lacking a little bit.
Mm-hmm.
But external rotation isn't too bad at all, and I think that's actually like a compensation for him too.
Mm-hmm. Mm-hmm. So yeah, that gait sort of matches the hips.
Mm-hmm.
Okay.
Any other things before we keep going down the list here?
No, let's move through.
Okay. So each time he comes into the clinic, and he's been in about 4 times now, I'd say. We just go through like a basic dynamic warm-up, trying to warm up all the, basically all the muscle groups of the lower extremity. And then he goes right into like putting the mini bands around the ankles and getting his hips strong and getting his hips a little bit looser. Sometimes we start with just like basic movements such as like clamshells and inverted clamshells and all those glute activation drills that we're probably all familiar with. I have his interventions listed out here, and some days there is an inherent order to it, and some days we've kind of gone off kilter a little bit. But I've been trying to stick to like the SFA model of you first work on everything in quadruped, then you move to tall kneeling, then you move to half kneeling, and then you finally work into your standing positions. So like going through like a basic day, he would do dynamic warm-up, mini bands. He'd really foam roll his calves because that seems to be helping him a lot with his mobility. And then after that, we'd work kind of like, we do some tall kneeling deadlifts with a stick, trying to keep him in like good neutral spine alignment and teach him that proper hip hinging form so he actually knows the motor control of how to load his hips before we strengthen him. We spent a lot of time working on TRX squats and not letting him just sit back into the squat. So we're like, I think you see that a lot of times where the knee is at like 90 degrees and the hip and the trunk are at 90 degrees. So if you let go of the TRX straps, you just fall backwards. But we've been actually working on using the TRX squats to develop motor control. We've been doing a lot of body weight squats with some pattern assistance and the mini bands wrapped around his knees so he can feel that pull into hip external rotation. A lot of body weight squats are being done where he holds a weight out in front of him. He has to set that weight down and hold the position at the end of his body weight squat, and then quickly fire up from the lowest position of his squats. So a lot of what we worked on was a bunch of basically tall kneeling positions to teach him hip loading and neutral spine position at the beginning. And then now what we've kind of gotten into is actually adding weight to some of his lifts, such as we've gotten more goblet squats going. We've actually worked on some front squats with the barbell. We've been working on deadlifts with kettlebells and with the bar, and then also just turning into a motor control exercise where he just uses like a kitchen broom and stuff like that.
Okay.
And generally in between each motor control exercise or between each hip strengthening exercise, you always make him do like a core exercise such as RKC planks or side planks or bear crawls as well in between sets.
Nice. Okay.
I should mention too, I usually when he comes in, unfortunately with the way our clinic is kind of working right now when we have a ton of people, is he's usually doubled or tripled up with someone. So like I would like to do more manual work on him, but I've been doing a lot of hip mobility with the mobility bands and stuff like that to try and open up his hips a little bit more. So I really haven't had a chance, just given the nature of how our clinic's working right now, to do manual work on him.
That's no good.
Yeah. It's just been super busy. So
I think that, I mean, given his ankle motion limitations, whether it's calf or not, whether it's calf or talar curl joints, I think you've got to work on his ankles, and I think you have to work on his hips. I mean, even if it's just for 30 seconds or a minute, but that manual therapy, I mean, that's gotta come, before this other stuff. I mean, otherwise, I mean, you can motor control the heck out of it, but if you've got significant limitations in your motion, I don't think you can't out strengthen your mobility issues.
Yeah, and I certainly agree with that. I'd also say, just like by watching him do all this stuff too, that he has gained a lot of mobility in all those areas, and I think it's a lot of, like, he's bought these bands at his home, and he's gotten foam rollers and lacrosse balls and stuff, so it's something he's really worked on at the same time too. So otherwise, yeah, I would like to step in and do a lot more with him.
Even a little bit, but don't feel like you have to do 10 minutes of manual therapy, but just minute both hips, minute both ankles, and send him on.
Did you check a modified Thomas on him?
Yeah, as we've gone on, he's actually pretty good on the Thomas test, but he actually his hamstrings are super tight. Whether it be an active straight leg raise, and neural tension tests don't really come up. I know I didn't write that down. Don't really come up as a positive or anything, but when you do a passive straight leg raise, he's missing about like 30 degrees of motion just right there. So that's another thing been working on too.
So Carson, I had a quick question. What is the funky chicken with hip hinge position?
Oh, yeah, sorry. So you strap mini bands around your knees. You throw a stick behind your back so you keep neutral spine, and you hip hinge. And then you either quickly fire with a bunch of like hip external rotation sets, or you keep one knee stable and move the other knee out against the resistance and go back and forth. And it just really tires out the glutes quickly while he's holding the motor control position.
Gotcha. Nice.
Percy, you haven't been doing the funky chicken?
I might have to do that tomorrow. On Sunday.
Oh, man. You're missing out.
That's the key.
All right, hey, I think we got to get moving on to the next case. Carson, I love the progression that you did, especially going quadruped to half kneeling to full functional standing. And I think the exercises are great, but kind of like what Dana said, definitely hit hip internal rotation, do quick manips on the hips also, and then, you got to get the ankles moving.
Yeah, for sure.
I guess just, sort of two things real quick. If you were to sort of where he's at now, kind of quickly, and then what do you think has been the most effective?
So I actually think most of the motor control exercises are the most effective, because he can actually almost pass the overhead squat breakout of the SFMA, and he now has like a fairly normal gait pattern, and he's not doing everything on his toes. And he's actually just about to go get checked out with the doctor to compete in basketball and stuff like that. And I would like to add like a lot of more lateral movements and transverse planes movements too, but motor control has been the task right now. So he's doing well overall.
Okay, very good.
Nice. Great case.
Oh, just FYI, he's getting checked out by the physician.
Yeah. Who did I say? What'd I say?
Doctor.
Oh, yeah.
That's you also.
Yeah, that's right.
Okay. All right. Who wants to go next?